what I've done is I've actually added another paper after the first paper to compensate for the controversy.
I'm very grateful.
So the first paper, as you can see in the title, is actually evaluating the effects of liothyronine on quality of life in female hypothyroid patients with residual symptoms, and it's a crossover trial. And the background generally to it is that we all know that there are, like, levothyroxine is good in alleviating symptoms for up to 90% of the patients, but there are, like, according to different studies, 5 to 10% of the patients remain dissatisfied and have residual symptoms. And the previous literature have shown that these symptoms are generally cold intolerance, fatigue, weight gain, cognitive impairment, and mood disturbances, and overall reduced quality of life. And combination treatments, so therapies including both levothyroxine with liothyronine have been suggested, and they are based on the hypothesis that there may be polymorphisms in the deiodinase 2 gene, and therefore there is reduced conversion of T4 to T3 in certain individuals. However, previous studies of these combinations have largely been negative, and those who have been pro-liothyronine, they are critical of for various reasons. They felt that in these studies, the sample size was small. The populations that were included were not very symptomatic. The half-life of T3 is short, and generally these designs had once daily levothyroxine, liothyronine combination. And a few of those patients that were included were actually over-treated, and they had suppressed TSH, and therefore they were symptomatic due to hyperthyroidism. Moreover, there is literature suggesting that in those who are treated with levothyroxine, there is a higher ratio of T4 to T3, and that happens by reducing T3, and hence those who are being treated with levothyroxine monotherapy have lower T3 availability. So the Norwegian group who has carried out this study wanted to assess quality of life using levothyroxine and liothyronine as a monotherapy on quality of life particularly, and they have looked at the association of deiodinase 2 polymorphism with quality of life. So this is the trial design. So they randomized 62 participants after sort of initial assessment for eligibility, and there were 35 and 34 in the two groups. I think the main problem with this study is that it's a non-blinded study. So the participants as well as the investigators were aware what they were treating them with, and then they included only female hypothyroid patients with residual symptoms. And the way they have defined residual symptoms is they devise their own questionnaire, which is, I've looked at the questions, and they are really yes and no questions of hypothyroidism, addressing skin changes, mood disturbances, so physical sort of fatigue and tiredness, constipation, so all those things. And they graded those who had more than 3 symptoms. They included them in the study. Those who were previously on combination therapy or DTE, desiccated thyroid extract, they were switched to levothyroxine at least 4 weeks before randomization. So they were all the patients had to start with were on levothyroxine. They've excluded other endocrine patients with other endocrine conditions, pregnancy, psychs, like the common exclusions, those who are on interfering drugs that could affect thyroid metabolism. So they've tried to exclude they have excluded all of those. And the way they decided on the levothyroxine dose is they basically use 1/3 of the previous levothyroxine dose, and then they divided into 3 divided doses. But there was no washout between therapies. The participants were asked to come in every 4 weeks, and they were really aggressive in trying to achieve sort of a near suppressed TSH in their aims of treatment.
So that's not in the reference range. The bottom end of that is outside the reference range.
Yes. So yeah, that's the first thing that struck to me. So the assay that they have used has a 0.4 as a lower limit of norm, but they were aiming for 0.1 to 1.5. Although they, I mean, when I'll discuss the results, they haven't really quite achieved that. The TSH is less than 1, but it's not suppressed.
Okay.
Did they say what their logic for the 0.1 was?
No, there is no mention of that in the paper of why they were trying to achieve that. So their main primary outcome measures were quality of life questionnaires, and these are the 3 questionnaires that they use. So ThyPro questionnaire has 85 items, the scale from 0 to 100, and higher score indicates poorer health status. And there is an abbreviated form of the questionnaire, which is 39 items. And that was actually used in 26 participants in the study. The other is the sort of a commonly known SF36 questionnaire, which has 36 questions, again, a scale of 0 to 100, and higher score here actually indicates better health status. And then there is a relatively old questionnaire, which is called fatigue questionnaires, which has 14 items. And the higher score indicates higher level of fatigue. So this is the baseline characteristics of the population. And there are no real surprises. I mean, they have randomized them sort of accurately. The age at inclusion was like around 42, 10 years of hypothyroidism at least, and they were on levothyroxine. Most patients were actually on levothyroxine monotherapy, and the common etiology was autoimmune hypothyroidism. The TSH, as you can see, was 0.64 to start with. So they were like, they were maintaining a pretty good TSH even at the beginning. And then they were randomized. So I didn't discuss, but basically they randomized participants to have levothyroxine for half of them actually were switched to liothyronine, and they took it for 12 weeks, and then they were switched to levothyroxine, and they took it for another 12 weeks. And there were assessments every 4 weeks for thyroid functions and adverse effects in these participants.
I wonder why they blinded. That sounds like it's quite easy to do blind.
Yes.
It would have been.
I mean, they have allocated like 3 paragraphs in the discussion about why didn't they blind it, but I'm not convinced why. Like they have basically cited logistic reasons and expense, and the fact that they may need the patients may need extra tablets because the liothyronine has a shorter half-life and levothyroxine has a longer half-life, and therefore they felt that there was still a possibility that the participants would eventually know what kind of treatment that they are on. But I don't think I'm convinced.
So there were a third of the normal. So if they were on say 60 of T4, they get 20 of T3 in divided doses. They divided by 3. Is that right?
Yeah. Yeah. So, and then they sort of administered this their own designed residual hypothyroid symptoms questionnaire, and most of them were fatigued and had cold intolerance. So these are the outcome measures. So this is the first outcome measure, fatigue questionnaire, and this is the radar plot. So basically, it's a combination of physical fatigue and mental fatigue assessed through questions, and the combination of two gives you the total fatigue score. And the blue line indicates the levothyroxine LT3 treatment. LT4 is the yellow, and the third one is from the baseline. I don't know whether you can see it, but yeah. So essentially, the lower the score here, the better their health status is. So they have demonstrated that people who were treated with liothyronine had a reduction in their physical fatigue, mental fatigue, and that was statistically significant. And then those who were converted from levothyroxine to liothyronine as well had a statistically significantly improved fatigue and well-being. So that's
so they all got better, even the T4 made them better.
Yeah, so the T4, so I think this really means that the half of the study arm who were actually on levothyroxine to start with and then switch to liothyronine, that's where they improved. This is where the participants who were on levothyroxine stayed on levothyroxine, and then or the ones who were switched from liothyronine to levothyroxine.
Yeah.
So they didn't show any improvement, but the ones who were switched to liothyronine had improvement in their fatigue, because they knew, I think, that they are going on the wonder drug.
That is right. I must say that last slide with that red, yellow, and blue thing makes it really okay.
So this is the SF36 questionnaire, and again, we have similar results here. Now here, as I said before, so the higher the score means better well-being, better health status. So so again, the liothyronine seems to be performing much better than the levothyroxine here, and that's particularly true for some of the symptoms, but not all the parameters or the items in the SF36, which is vitality, social functioning, and mental health. So in these parameters, the participants were doing well. Then this is the ThyPro questionnaire, which is thyroid specific quality of life questionnaire. And it is valid for benign thyroid diseases, both hypo and hyperthyroid. So you have symptoms like there is questions for hyperthyroidism and eye symptoms as well. And again, the lower the score indicates better sort of well-being and health status. And again, they're showing that the liothyronine actually performed much better than the levothyroxine. That's the table for that assessment. But again, I mean, there are no surprises here, but obviously the hyperthyroid symptoms or the eye symptoms did not improve. The rest of the markers did improve. So the other results that they have quoted on is the detected polymorphism in 61% of the patients who were included. But that really didn't correlate well with their quality of life scores. So they were surprised with the result. Then they have also asked about participant preference, and obviously
they've looked at, the polymorphisms in the D2 they've looked at, have they shown that they've got reduced activity?
No.
Sorry, I missed the question, sorry.
They shown that those polymorphisms reduce the activity of the deodonates.
Yes, they don't. I don't think they have actually looked at the activity per se. They just looked at the genes.
Yeah.
But has anybody else shown it?
No, there's a paper that
Has
had
it been
to
in,
be,
is that right?
which was, it is quite, it's just it's a snip.
Yeah, but if you don't show what the function of that snip is.
Yes.
Yeah, yeah. But in this paper, they haven't looked at it.
And it hasn't been shown to be functional. In that there's this mutation that seems to have no difference in the levels of T3.
So at the end of the study, they asked what would patients prefer as their treatment, and 16 of them still preferred levothyroxine, 28 preferred liothyronine, and 3 had no particular preference. And they were sort of monitoring for cardiovascular side effects by physical examination at the end, at each visit, which was 4 weekly, and they didn't find any differences in heart rate or blood pressure. But there were dropouts in the liothyronine group due to hyperthyroid symptoms. And they have commented that because they included younger population and cardiovascular disease was like an exclusion criteria for them, the adverse effects of liothyronine are probably underestimated. Plus, they did not use 24-hour tapes or other things to look for sort of paroxysmal AF or other things. And plus, the study they felt was of a shorter duration, and maybe longer treatment with liothyronine may exert some cardiovascular effects. And as we have discussed before, so basically, I think the main limitation, and they have acknowledged it as well, is the unblinded nature of the study. And hence, I think there are like 3 studies which have not used blinding when they are looking at combination therapies or LTE, and they have shown superiority over levothyroxine, but all the blinded studies have not shown that superiority. Plus, they have commented on the fact that the residual symptoms, that questionnaire that they used for inclusion, is not a validated one. It was mainly based on, I think, physician's judgment. The questionnaire is just a yes and no and a tick box, basically. So these were the limitations of this study.
Yes.
But this is the first study which has looked at liothyronine monotherapy in patients with residual symptoms, and they have used it alone, and they have shown improvement in quality of life. The other study that was published like 7 months ago is the study from US, and they compared the levothyroxine against DTE and the combination. So this is the study flow for this one. So they randomized 90, but there were 15 dropouts. So there were like 3 groups. Each of them stayed on, was allocated to each of the therapies, and then after crossover, they were switched to the remaining 2, half of them, and then for another 22 weeks they stayed on that one of the other therapies, and then crossing over again, and then stayed on the 3rd therapy. So this is a double-blinded design. So they actually manufactured their own identical capsules of the 3 therapies. And their inclusion criteria was they include both sexes, aged 18 to 65, those who were stable on levothyroxine, and because they were looking at sort of weight changes and SHBG and plasma leptin and other things. That's why they had weight, I think, as the in their inclusion criteria. And they had similar exclusions to the previous study. And they advised participants at the time of randomization to not make any significant sort of changes in their diet, exercise, medications that will affect the study outcomes. So here, the thyroid functions after randomization were checked at 6 weeks, but their aim was a TSH of 0.27 to 4.2. So, not as aggressive as the other study. And if the participants were within target, they then stayed on the same dose for additional 16 weeks, and then they switched to the next study and so forth. And these are the different combinations of doses that they have used. So they had 9 different types of capsules and levothyroxine dose ranging from 88 micrograms to 250 micrograms. So if a participant attended for, let's say, so the physician who was changing the capsule based on their patient's TSH was blinded of their existing dose. They were just advised to switch to the next dose in line, next capsule in line, basically. Or they may need to just, if the TSH was suppressed, they would go to a lower dose, but they were blinded of the actual doses.
That's a really good design, isn't it?
Yeah.
Yeah.
Yeah. So yeah, this is a much more robust design to assess sort of quality of life outcomes, I think. And then they have reported the levothyroxine dosing. So at the beginning of the study, the levothyroxine dose was 115 micrograms, and it's similar at the end of the study period. Similar doses for DTE, and the combination were at similar doses as well. So didn't really need to change the doses much during the course of the study.
And it's gone on for 66 weeks, so that's over a year.
Yes, yes. So they required like 3 years worth of recruitment and follow-ups. So their outcome measures again were included questionnaires and cognitive testing. So some of them were sort of thyroid specific, which is thyroid symptom questionnaire, which they have developed and validated before, and the rest have been used in other researches. But they were also testing for clinical and biochemical parameters. They're doing ECGs. And they're doing some fancy tests such as this T3 resin uptake test, which I read for the first time. And then they also looked at the deiodinase 2 polymorphism in their study.
So what's the T3 resin uptake test?
So essentially, it's the capacity of the thyroid binding globulin to bind thyroid hormones. So in a way, it's a bit like transferrin saturation, but I think I had a quick whiz through, but in hyperthyroid patients, the T3 resin uptake will be higher. The typical resin uptake is like 20 to 50%, but in hyperthyroid, it will be higher, and in hypothyroid, it will be lower. So that's how I've interpreted it, or looked at it. So this is the baseline characteristics. So relatively sort of older patients, and both male and females. Again, Hashimoto's as the primary etiology, and TSH in these participants was 1.77 as opposed to 0.63 in the other study to start with. And we've discussed the doses before. So yeah, that's what it shows. And these are the outcomes. So they had a negative result in their blinded study. So as a group, the participants did not have an improvement in their quality of life outcomes, their cognitive testing in the questionnaires that they employed. Despite the fact that they had changes in the various sort of biochemical parameters. So their TSH was a bit like it was higher in the combination, surprisingly, and then their T4 to T3 ratios were different in the 3 groups as well. And so this is basically, then they did a sub-analysis and they divided participants into 3 groups by according to the scores on the thyroid symptom questionnaire score. So they divided them into terciles. So the 3, and then they looked at different things again. And here, so now this study wasn't powered to look at a subgroup analysis. But then they looked at the patient preference and whether there were any differences in those who were more symptomatic. So H indicates poorer quality of life and more symptoms, and L indicates sort of better in terms of health status and symptoms. So those who were most symptomatic did not prefer levothyroxine, and they actually preferred the combination LT4 and LT3 combination. Those who had moderate symptoms, they again did not like being on levothyroxine, and they actually preferred DTE. Whereas those who were not that symptomatic were happier. I mean, overall, they were still, if you look at them as a group, there is more proportion of people who did not like levothyroxine. But yeah, in comparison to the other groups, there are still more people here in this group who were still happier with the levothyroxine. And so because this was a subgroup analysis, they set the significance level at less than 0.001 instead of the standard 0.05. And here, like these graphs are showing the change in their different symptom scores from baseline after treatment. So when they were switched to the combination therapy, those who were most symptomatic had an improvement in their quality of life when they were assessed through thyroid symptom questionnaire and GHQ-12. Whereas it's the other way around. So basically, in the group the VMI questionnaire, which is the visual memory index, those with the lowest scores indicate the worst quality of life. So they actually showed an improvement in their quality of life and cognitive testing. And this is the box plots for using DTE. And again, it has shown similar results. So improvement in their thyroid symptom questionnaire, GHQ-12, the VMI in this group. So this is the subgroup analysis they did. And this is what I've discussed before, but essentially they asked them to rank the treatment preference at the end of the study, and the participants chose TT and LT4 and LT3 as their treatment preference in 2/3 of the cases. So, so mind you, this paper was published like 7 to 8 months before the first study that I presented today. So they were, I mean, their discussion suggests that the studies are generally not directed at people who are most symptomatic or and dissatisfied. And they've discussed that the T3 containing therapy elevates T3 and reduces T4, and therefore, is that the reason? So basically, they have mainly commented on the residual symptom, the subgroup analysis, because that felt more exciting. So there is there an effect on the residual symptoms of this slightly higher T3 level? But they did a correlation analysis and they did not find the correlation between serum T3 and the quality of life outcomes. So then they are raising question whether there is a role of intracellular T3, which will be not just affected by the serum T3, but the locally generated T3. And then there is discussion about the cerebral T3, which is produced locally in glial cells. And patients who remain symptomatic on levothyroxine, is there a defect in their thyroid hormone transporter, DIO2 pathway, or relatively low serum T3 levels in these patients that are rather not enough to improve their sort of mental health and general well-being. So they have commented that yes, their study wasn't powered to look at the subgroups, but this was the most exciting analysis. And like otherwise, the trial really did not show any improvement in the quality of life quality of life. And one may argue whether this was just regression to the mean, but I think they've shown that patients who tended to do poorly on levothyroxine showed larger improvements. And again, those who in the previous slides, as I've mentioned, that there is less preference to levothyroxine in those who were more symptomatic. So again, they have concluded on similar lines that maybe we need to consider the most symptomatic dissatisfied patients and see whether they will actually benefit from combination therapies or DTE or and whether there is a role of liothyronine in such patients. And they recommended obviously blinded trials of longer duration to answer that.
Yeah, thank you. That last bit's quite interesting. And the problem is the power. It might be, yeah, got to think about that. What you're saying, I guess, is there's a small proportion potentially number who actually might benefit. We're going to find them, and a lot of people don't benefit.
Why might those people benefit?
Well, in the sub-analysis, a small portion of people, they said they preferred the tablet that turned out to be
The T3.
the T3, not knowing what it was.
But
Which
it
is
didn't
quite
show any objective benefit.
No, so the main finding was no benefit, but so there is a possibility that this is, as you said, regression to the mean. When you start doing small group analyses, but it is interesting. It's in the right direction, isn't it? Can't deny that.
Yeah.
But there's a big overlap there.
Yes.
So it might not be real, but it's the kind of thing that makes people stop and think, I wonder if it might be real. And then the website starts saying, there's a paper that says it might be real, followed by we should all be on it. And this deodorinase thing has gone mad. There's a company for £100 that will check your SNP to see if you've got the D2 deodorinase.
Yeah.
And it's terrible, really, because it doesn't mean anything.
Is it just that a percentage of people have that?
Yes,
In the whole
a third of the
world,
country, a third of the world have got that SNP. And they say, well, if you've got that, then maybe you'll benefit.
But it's
And
not,
so-
there's no,
In the Norwegian group, they said that in their general population, it's 11%.
okay.
Yeah.
So there's a 1 in 10 chance of you having that SNP. And so, but they think, well, they're the ones who need it, but actually it's a random piece of genetic material that doesn't seem to correlate really with any activity.
Was the combined group once a day?
Sorry, say it again.
The LT4 and LT3, was that once a day?
Yes. So this trial had once daily treatment.
It was blinded. So this is a much better
But
study.
the other study's crazy, you're not going to do T3.
Yeah, that's why I
the
said
other study, you took
frontiers.
it 3 times a day versus once.
Well, the other study, yes, the other study was
And
not
you-
blinded, and you knew they were on, and that's why
So
in
it doesn't
Frontiers.
tell us anything.
I mean, Frontiers is really becoming a sort of predatory journal. I mean, doesn't anything now. It's a problem.
Sorry.
Oh, Amir,
Hello. Hi. Can I ask a question about the dosing, Mohsin? So if
Yes.
100 micrograms of T4 in the first paper, would they end up on 10? You said a third, and then divided into 3.
Yes. So they will be on 10 micrograms of liothyronine 3 times a day.
A little bit less than the 100, so it's about 90. Yes.
Yes.
Okay. So, but in the other study, it wasn't. The ratio was different, correct? Because they were on.
in
Yes.
this study, nobody was on T3 alone.
Yeah.
Combination again. So does that mean that all these tired people that come to the T3 clinic are now going to ask for T3 on its own?
This is a new problem.
Having told them that the combination doesn't work, they're all going to come with a copy of this paper and say, now I want T3 on its own.
Yeah.
The point of being the Frontiers one, I mean, that's just, yeah.
That doesn't
it's
show
a
anything.
newspaper.
That doesn't show.
It's not blinded, so it shouldn't be published really. It doesn't show anything, and that's why it's not launched into a good journal.
Because if you come in and say, I'm really tired, I want to try T3, you give them T3, you say, I am giving you T3, are you less tired? They'll say yes.
Yeah, that's what they showed in that first paper. You basically summarized the first paper nicely.
Yeah. Yeah.
The paper is showing that people who feel worse prefer the combination, is that right?
It seems to be that, yes.
But that was a subgroup analysis, it wasn't a primary analysis.
Yes.
Primary analysis says
The
no.
primary analysis, there's no.
I think that's very helpful. Primary analysis is no different.
Yes, yes.
I'm going to remember that.
Mm.
And that was
Yeah.
75 patients, there was subgroups like 30.
Yeah, here's the problem when you have small groups, you start to have a problem with error bars get wide, and so you change your settings. Vicky,
Hi, I kind of sort of get the same feeling that you had, Kareem, which is that there might be something in this subgroup analysis, which has obviously not been conclusively answered here, but you can kind of come up with a reason for why symptomatic patients may, for whatever reason, have, for example, less brain activity of DIO or transport of T3 or whatever. And then there's the question as to whether this is just showing some kind of regression to the mean phenomenon. Now, in your experience, what proportion of people who are tired and persistently tired ever regress to the mean? And how would you design the next study?
that's a good question. So I've got a few patients who have voluntarily gone for blinding because they want to know if the T3 helps them. And I've got about 70, and done properly blind, about 5 or 6 of it have done it. And they come out of it saying, I'm quite happy to not have T3 anymore. There are 2 other things. All of them are also on a whole load of supplements. They're not just on, they're on coenzyme Q, they're on ashwagandha, they're on all kinds of hocus that, and they're tired people. So they're tired people looking for help. And if you spend the time with them, some of them, it's not a study, of course, I'm just telling you my experience now. A lot of them have had some terrible event in life that has helped them be very tired and depressed or whatever. And many years have gone by and they're still on T3. And of course, the problem has been that NHS England said you can't have T3 anymore, and they're having a panic. But in fact, if that primary event has been solved, they are quite happy to come off T3 without a problem, and the slow weaning protocol and all kind of things. But I've now got a bunch of people on T4 and who are interested in taking part in this kind of study. And the study that I'm thinking of doing is to have them all on thyroxine and adding something like 10 micrograms of T3 or placebo or a bit of extra T4, and seeing what happens as well. I've got some data on a few people, and they don't show any benefit of extra T3, except they become slightly toxic when they do that. So that's my experience. So I'm quite biased in the tiredness being due to things that respond to placebo, let's call it that. And I've seen quite a lot of good placebo responses. And I think, you know, coenzyme Q and ashwagandha are good placebos, and turmeric, that's the other one. You know?
Yeah, because it kind of makes you think to what extent randomized controlled trials are the right answer here. And I know that there's obviously the ethics associated with actually actively lying to a patient about what you're giving them. But I mean, do those trials exist outside Professor Miron's clinic?
So I don't lie to them. I am completely. I would never. You know, so they know what we're going into is these capsules have either got this or this or this, and it's completely right. But I get somebody else to do the blinding, so I'm blind to which of those it is too. But what I need to do is to get it manufactured, because currently we just use encapsulation. But if we can do, I mean, there are 2 or 3 publications saying we need to take this group of tired people. I mean, that was published about 2 years before this, saying who should do the study, because a lot of negative studies, as you pointed out here, are people who are not really the tired group. They're just hypothyroid. If you take normal hypothyroid patients, there's no benefit. But if you take people who are very tired as well, the question is there a benefit? And in this study, you said there's no benefit, but in the subgroup analysis, there seems to be. So that needs to be, I think, before I completely write off T3. But to do that blind will be a huge funding issue, because what I've discovered is that to get blind drugs is very expensive. That's the problem, because you need to manufacture it, you need to get MHRA approval, they need to inspect your placebo production. That is very costly. So you need a grant of, you know, 200K or more probably. And for the state support, because there won't be industry support for this, there's no money in it in the end. So if you want to know a question about something that's not expensive, it's going to be very hard to do. Hence this open label study, the Norwegian study, they just got some T3 and some T4 prescribed it. That's easy. It was legal.
So you want to do that on all tired patients, and if you want to just on tired patients.
Yes, and that's the
Tired hypothyroid.
So the people coming to our clinic now for the T4 withdrawal service, they are very tired.
Yeah,
They're
so
a
that
really
group-
good group.
The group that have been referred in,
Yeah.
because they're on T3.
Yeah.
But if you have a company that makes T3, which costs how much now?
Okay, so there's the T3 price is coming down. There's 2 or 3 companies that competition is starting to set in at last, and it's come down from £245 to 55. So I think that anything will probably go away
So how much? 45?
for a month's supply
45.
instead of 245.
It's much better than a few thousand. Or 1,000, 2,000 a year, right?
Yeah. So currently, so the problem started when it was £200 a month.
Yeah. Why
So
don't you get that company to fund it?
they don't want any research that might dent their massive.
I don't think it will. I think you'll find that there's a benefit, but in terms of cost effectiveness, there's no way that this can be cost effective.
I don't know.
Well, patients won't buy it anyway, won't they?
Well, if you're buying
Patients
it,
won't buy
then you've
it.
got to buy. There are 2 much cheaper sources from overseas that have got, and it's legitimate T3 because I checked the TSH and it's suppressed, so it does work. There's a supply from Turkey that works Tylenol.
And when you've got them on the T3 as well, are you seeing that the TSH stays in the normal range?
No,
That's what I was
No.
worried
the,
about.
the patients who are taking T3 all have a completely suppressed TSH.
And what about in the first study? I'm so sorry, I missed the data. Was the TSH all right on just
It was,
T3?
they aimed slightly low, 0.1, but not completely suppressed. Because all the patients, when they referred to us, they start with TSH less than 0.01. You know, and they come off it, and then with some support.
Is there a known difference between people running themselves a bit toxic on T4
There are plenty of those.
versus people adding in
So-
T3
so the problem-
and being toxic? I mean,
So no one, patients then tend not to cross over. Once if they're happy on being on a bit too much T4, we've got plenty of those, then they elect to stay on that. And I guess that the real, I mean, if they're biochemically toxic and toxic, then they're going to get osteoporosis in AF. That is the problem. And the patients I'm seeing on T3 are in that group. They're younger, so they're not yet had the complications, but it'll come. So that's the thing. Hey, that was a really good summary, Mohsin. There's some more hands.
Thank you. I think if they had blinded the Norwegian study, probably would have had the answer by now.
I agree. They could have, couldn't they? They could have blinded it by having
Yeah,
what Moving's doing, which is you have a blind placebo for 3 times a day.